So, thank you so much for this kind invitation. The subject of today, of course, is a difficult one. We're going to talk about anesthesia, analgesia, and it's terribly challenging because we, I think, at present have no real explanation for consciousness. And you're here, the experts, you're taking away consciousness, trying to monitor it and trying to bring it back. So how do we do that? And our domain of expertise in Liège is to look at not so much pharmacological coma, but pathological coma. So we have patients with severe brain injury, and we're using functional imaging to try and reduce the uncertainty about their... Okay, so how can science explain consciousness? I'm a neurologist, a neuroscientist, and I think that the question has long remained purely philosophical. And I think that now has changed because we have these machines that permit us to look inside the living brain and we can test our hypothesis. However, I think that despite all the advances in the past 20, 15 years or so, it still remains kind of a miracle. If we try to go from something material, our brain, these thousands of billions of connection synapses, something we can grab and try to understand how that somehow creates our thoughts, our perceptions. In between, as you see here, this is a cartoon made by my brother, we have a gap. And of course, as scientists, we do not like the miracle explanation. And therefore, I think it is good to kind of reduce the complexity of what we call consciousness to two main dimensions. And you've seen this graph, I think, on the brochure and the poster. It's basically just reducing consciousness to its two main components. And that is the level of consciousness, which is wakefulness, arousal, vigilance, which is, as we'll see, necessary, but not sufficient. And then there's the content, which we call in English awareness, awareness of yourself and your environment. And I like this definition because it kind of explains what consciousness is based on our daily experience. I hope you had a good night of sleep, and consciousness is what you lose when you fall asleep. And that is because on this graph, your level of consciousness or arousal will go down up to the point where you lose awareness of what's happening around you. And already we see that there is a notorious exception, which is REM sleep, rapid eye movement sleep, where dreaming occurs, which illustrates how difficult it is. You as an anesthesiologist faced with a patient who looks asleep, unconscious, but how sure can you be? Just as when we look at a sleeping person, he can have some conscious activity during dreaming. Especially interesting, I think, is lucid dreaming. Lucid dreaming is the fact that you become kind of aware of the fact that you're dreaming. And you can actually control your own actions. It's, I think, a wonderful window on our understanding of consciousness, and yet it is very little studied. It was kind of taboo. The sleep community wasn't very interested, and so there's very little peer-reviewed research on lucid dreaming, where now this starts to change, and there's papers in high-impact journals where we use conscious awareness during REM sleep, where you can actually communicate with subjects through eye movements, and you can just explain them. If you're lucid during your dream, just look left twice, look to the right once, and then we can measure brain function. We can try to see what's happening. And I think this is an interesting dissociation between wakefulness and awareness. Now, the subject of today, of course, is pharmacological coma, anesthesia. By definition, coma is a patient who cannot be awakened. So even if you stimulate him, he will never open the eyes. And this is our clinical index of the level of consciousness or wakefulness. It is quite simple. I look at all of you here. You all look awake, eyes wide open, so chances are you're actually aware of what I'm saying. It's quite early, so maybe those who had a tough night could fall asleep, and then you could, become unaware of what's happening here on stage. Now, coma is somehow comparable, but also very different from general anesthesia. It's kind of a big debate. Of course, it is reversible, and it's caused and controlled by the different drugs you give. Pathological coma is classically due to a massive traumatic or anoxic brain injury, and it doesn't last very long. Classically, it's a couple of days or weeks, or things go wrong very quickly, and people evolve to brain death, which is death based on neurological brain criteria, or they recover, communicate, and this is, of course, the aim of intensive care. But since the 70s, we know that there's a very strange entity where patients recover, awaken, open the eyes, starts breathing spontaneously, moving, but when all these movements are considered reflexes or automatic, this was coined persistent vegetative state. I prefer a more neutral term, which is unresponsive wakefulness, because this is actually what we see. We have these kinds of artifacts of modern medicine. They survive their coma, awaken, yet we think remain unaware. Why do we say that? Because they don't pass our awareness test. If we say wakefulness is simply looking at eye opening, awareness is looking for response to command. So that works fine most of the time. It's also what I think you all do, asking patient, squeeze my hand. If he does it, fine. You're convinced that he's conscious. There's no philosophers in the room, so my lecture will be quite easy. The problem is if the patient is not answering, if he's not squeezing your hand. Is this truly proving that he is unconscious? No. Definitely not in my field, because after traumatic brain injury, the patient can be deaf. So this is why we'll write it down. But I think also in your field, we need to be very, very careful and really not to be too arrogant and understand that all we're doing at the bedside can be biased by this motor responsiveness we're monitoring. We're actually wanting to know if the patient is conscious, but what we're doing is making inferences based on a motor response. Now, there's other examples of this, I think, very intriguing dissociation between wakefulness and awareness, and that is sleepwalkers. During deep, slow wave sleep, some subjects walk, and they will also fail the awareness test. If you ask a sleepwalker, do this, do that, he will not do that. I think it's another interesting model. Like epilepsy. Some patients with absence seizures where, oops, what did I say? For a couple of seconds, you're gone. Or complex partial seizures where you can have automatic behavior. Some patients even committing a crime, and then neurologists have to say, was it really him or was it the epilepsy? Very challenging conditions where you again have a dissociation, you fail to pass the awareness test, there's no response to command, and yet you have motor behavior. Now I think a big change in our field, and I think it's also important for you to know about this entity called minimally conscious state. And maybe we should say minimally responsive state, where patients do show some behavior we can't consider as purely reflexive, yet they can't communicate. This was coined 2002, and we now subcategorize this in minimally conscious state minus, where patients will, for example, smile when their mother is in the room, and only if it's their mother. You can't say it's a reflex. Or they will orient to pain. They will push you away, which for us neurologists is the first sign of non-reflex behavior. Classically, it's an abduction or location of the point where the noxious stimulation is performed. Or they will track with their eyes. This is minimally conscious state minus. There's so-called non-reflex behavior. And then the next step are those patients who pass the awareness test, who show response to command, but by definition can't use this to establish a functional communication. So you can't say squeeze my hand twice to say yes, look up to say no. Very frustrating because you know sometimes the patients are conscious and you can't access that because awareness needs to be shared. And then, of course, there is this terrible, unfortunately rare syndrome of locked-in patients. Now, these patients, as you know, they survive their coma and then awake, fully conscious, yet paralyzed, classically caused by a brainstem lesion, a stroke, cutting all their motor fibers, and leaving them only with some voluntary control of blinks or vertical eye movements. It's an intact brain disconnected from any voluntary muscle control of the limbs and of facial musculature. So, we've reduced the complexity of consciousness to these two dimensions, and normally you have this kind of positive relationship you experience every night. When arousal goes down, so does awareness, and I think this is what your drugs are doing. It's reducing the level of arousal, and so patients lose awareness of their environment, and hence we think of their self. Now next, I would like to propose that, again, awareness can be reduced to two main components, which is external awareness, you see here on the axis, sensory, perceptual, everything coming through your senses right now, what you see and hear and feel, external awareness, and then internal awareness, which is basically all the rest. This little voice talking to yourself right now, mental imagery, what am I going to do tomorrow, what did I do yesterday? You could coin it self-awareness, but I prefer to talk about internal awareness and external awareness. And I think now, and this is kind of the take-home message of this talk, we do know where this, or we think we know, where this happens in the brain. You don't need your whole brain to be conscious. There's a critical awareness network. External awareness seems to have a neural substrate different from internal awareness. It's these frontoparietal associative cortical areas, both hemispheres in the front, in the back, colored here in red. If I would take your brain and a scalpel and remove this network, you would still be awake, breathing, but you would have no awareness of anything happening around you, according to this hypothesis. If we would remove the areas in blue, mesiofrontal anterior cingulate cortex, precuneus posterior cingulate cortex, this midline core, we think you will not have any internal awareness. This internal dialogue would disappear. Now, the strength of our brain, these billions of neurons, is their interaction. And this is illustrated by these big black arrows. One neuron can't be conscious. It's these thousands of billions of interactions where, of course, the thalamus plays a critical role. So it's the interaction between this network that we think, depending on the complexity and the capacity to integrate information, generate what we call feelings, external awareness, or thoughts, internal awareness. Right, as said, we need to be very careful because at the bedside, what we're doing is based on making inferences from motor behavior, and sometimes we can get it wrong. This is why, together with our colleagues in the UK, we developed this kind of strange tennis test. So we ask patients after coma, imagine playing tennis. Why did we do that? Because if you truly imagine to move, you activate your motor cortex. You see it here. I was asked to use my mouse, so I will be. So you see this region here, supplementary motor area, will activate if right now you imagine yourself moving or playing tennis. And this offered us a tool that didn't depend on any motor response and look into severely damaged brains. You see here a patient where there's massive traumatic brain injury. You see the scars from the outside, no response to command. Put the patient in the MRI, ask him, imagine to move, and surprise, we see activation very similar to healthy volunteers. And then we had many other questions like, imagine the face of your mother, sing jingle bells in your head. It turned out to be that the other very powerful task for us was asking patients to imagine walking around in their house. This will activate a very different set of regions, especially here around the hippocampus. You see here, very developed in taxi drivers. And this permitted us to really try and challenge our clinical diagnosis. It was published in 2006. Many said, well, this is not truly a sign of consciousness. Maybe this was automatic activation of the brain to the word tennis, or this was a 1 in a million case. So we just kept doing this, and a couple of years later published this paper showing, yes, you can have patients, you can see here again, with very severe brain damage. You see hydrocephalus, there's a lot of water, cerebrospinal fluid here. There's basically no gray matter left. No way to know from the outside if these patients actually feel or think, yet in the functional MRI, you ask him a question, they will not move if you look at their muscle, but their motor cortex will activate. And actually, we can even use this, my little trick, to communicate with them. So imagine this was a patient sent to us in Liège. Classically, they would come for 1 week. They come from Switzerland, France, Germany, with questions about their diagnosis. Are they conscious or not? Will they recover or not? And we use all these different machines to look and measure their brain function. And so this patient came with the label vegetative state, put him in the fMRI, ask him to move. We see the motor activation, and then we ask him, well, we know you're conscious. We're going to ask you questions. If you want to say yes, imagine to move. If you want to say no, walk around in your house. This is terribly difficult for a patient for years considered as a vegetable, so to speak, and being treated as such. And to our surprise, you can here see question 1, 2, 3, up to 6. The first 5 questions he answers correctly. You see here in red, activation of the motor cortex. We can read he's saying yes. Blue, question 2, he's saying no. 3, he's saying no, saying yes, saying no, and then saying nothing anymore. So for me, it's a proof of concept. Of course, this is not practical. As soon as the patient came out of the MRI, no way to communicate. So we need, with the engineers, to work on cheaper, portable systems. These are called brain-computer interfaces, where basically you do the same thing. Now you put electrodes on the scalp. You ask, move your foot, move your hand. We don't look at the foot or hand movement, but we check if motor cortex is activating. And we know Penfield foot is more median than hand. And in some exceptional cases, we can show that actually more is going on in their heads, in their minds, than we thought based on a motor-biased clinical examination. We can even use this using other paradigms where we see that this is already being translated to clinical practice. This was a young woman I saw in intensive care, a very extensive damaged brainstem up to the thalamus, basilar artery thrombosis, clinically no sign of consciousness whatsoever. Up to day 49, we did this event-related potential paradigm where, again, we asked the patient to do something. In this case, we presented her with a bunch of names, and she had to count every time she heard her own name. If you hear your own name, it's a kind of attention-grabbing stimulus that will lead to a P3 response in your brain. And if you count it, then this P3 increases in amplitude. It's what you see here in pink. And this was the only thing we had to say, well, this patient, despite all appearances, has response to command. There's an increase in this P3 wave measured with the evoked potentials that shows that she hears, understands, and actually does the task. There's now many more sophisticated ways. Here you see an example of time-frequency analysis to get this kind of proof of response to command, where in this case we continued the treatment and she subsequently recovered and she can now control her wheelchair with one arm. So again, an example of how new technologies, brain-computer interfaces, can offer us tools that we didn't have before. And there's one last example I would like to share with you, where we can actually communicate through looking at your eyes. Here you see a picture of my daughter's eye. Her name is Clara. And she's a teenager. It's not always easy to communicate with her. Here, what we do is we're asking her a question. Is your name Clara? Putting a camera on her eyes. And if she wants to say yes, she's doing a mental calculation. 24 times 57. Mr. Chairman, how much is that? If you try to do that, it's a bit stressful, isn't it? Your pupil will dilate, and I can easily measure that with a camera, feed it into a computer, and he will tell me, this is a dilation of the pupil, it's a yes, and we can communicate by just looking at your eyes. This works, as you can see here, fine in healthy volunteers, in controlled laboratory settings. It is much more tricky to do this in a clinical setting. Locked-in syndrome patients, where we know they're conscious, often will fail this test. But again, it's a kind of proof of principle. In some minimally conscious state patients, we could show that this is another channel. But at present, this is not plug and play yet. And there's still a big problem with all these fancy tests. And that is, and it's summarized on this slide, when we have patients who are comatose, being after pathology or anesthetized, when they recover, they will go through different phases. First, they will awaken, open the eyes, but only show reflex movements. The challenge for us is to identify non-reflex behavior, orientation to pain, visual tracking, contingent responses to emotional stimuli. And then there's the real consciousness test, response to command. That's difficult because it depends on the motor response, but it's also difficult because it depends on understanding language. So even the most fancy, imagine playing tennis or do 29 times 53, will fail if the patient is aphasic. If you're asking him, squeeze my hand, do this, do that, and for some reason he's just unable to understand your command, you're in trouble. And that doesn't mean, however, that he's fully unconscious, that he can't experience pain, that he can't have emotions, which is well illustrated in this slide, where we looked at minimally conscious state patients after traumatic brain injury, after cardiac arrest, surviving coma, separate them in those with and without response to command. We see that those without response to command, the button, have damage classically in the left dominant hemisphere, encompassing the language network. In other words, if we're trying to monitor consciousness and we're developing new tests, they should ideally not depend on understanding of language. So, historically, one of the first, and I still think very powerful measurements we have is positron emission tomography quantifying brain metabolism. So, you inject radioactive glucose, your neurons use a lot of energy. There's no other cell in your body using so much energy, and you can visualize that this is what it looks like in your brain right now, I hope. It's billions of neurons using a lot of glucose. Red, yellow colors in the gray matter, full 100%. The question we asked in the 90s was whether the quantification of brain metabolism could help to better understand consciousness in so-called resting state conditions. We don't ask anything. You just lay there awake, we inject the sugar, and we see how your brain functions. We started looking at the extreme brain death. There you have the empty skull sign. There's only the skin surrounding your skull that's still using some energy. When you're in deep sleep, slow wave sleep, overall brain activity drops to about 60% of normal waking values. When you're in REM sleep, rapid eye movement, where dreaming occurs, you see there's a return to nearly normal waking values. When you give your anesthetics with basically any drug, with very few exceptions, up to the point that the patient fails to respond to command, you will see the same massive global decrease that is illustrated here, a study using propofol. And of course, given that you're good anesthesiologists, when you stop the drug, consciousness returns, and so does overall brain function. So this seems to say that, yes, there is a relationship between overall brain function and the presence or absence of consciousness and awareness. However, and this is where I think it's interesting to look at pathology, and especially patients who are so-called vegetative or unresponsive, we see this is not the case in those patients who survive a severe traumatic or non-traumatic brain injury. You see, again, when they're comatose or vegetative, very impressive global decreases. But when they recover consciousness and functional communication, they don't recover a full 100%. In other words, you don't need whole your brain to be conscious. The study of these patients permitted us to identify the minimum neural activity needed for you to recover awareness. And this seems to be systematically the same frontoparietal global neuronal workspace. You see it here in red on the left, the statistical analysis between patients who are awake yet unaware, and matched volunteers who are also awake but aware. You subtract the PET images and you identify, to be a bit provocative, the awareness network. There's no single consciousness region. It's a widespread network, frontal, parietal, both hemispheres, and this midline core, where it turns out to be there is a very fascinating critical hub. This triangle you see there, highlighted in red, is the brain cortical region in your brain right now that is the most active. It's like the internet. There are some critical hubs which are more important, more connected to the rest. And it turns out to be that this region is the most impaired in coma, in vegetative. It is, of course, preserved in pseudocoma or locked-in syndrome, and it is minimally active in the minimally conscious state. So I think this region, called precuneus posterior cingulate cortex, is really important, and we should increase our efforts to better understand it. As you see, also in sleep, when you compare waking and stage 2, deep sleep and REM, you see this correlation in activity and awareness. And in anesthesia, this is again propofol, I think it's very clear you have this massive drop in activity when you are here in deep sedation, where the subject loses response to commands. So, a kind of summary. When we look at patients who are comatose or in deep dreamless sleep or in general anesthesia, we systematically have a decrease in activity in this widespread frontoparietal network you see in black. But these situations are a mixture between decreased arousal and awareness. And this is why I think it can be interesting, of course, from a medical and humane perspective. Vegetative or unresponsive wakefulness is a big challenge, but also scientifically, I think it can help to see this dissociation between recovery of wakefulness, yet without any awareness. And again, we see this frontoparietal network. So this is not just arousal. This seems to be really what makes us perceive the world and ourselves. Another example, you see regions in blue going down during stage 2, slow wave sleep, and then you see something particular happening in REM sleep, where there is still a decrease of the internal awareness network. There is still a decrease of the external awareness network because you don't perceive your environment in REM sleep, but there is a relative recovery of the internal awareness network when you are dreaming. In propofol anesthesia, the whole network will go down. This is a study we did with Vincent Bonhomme on clonidine. Very interesting because it creates these spindles, and again, you see the network going down. We also use the BIS. I think you all know this FDA-approved consciousness meter that we think reflects some conscious processing. It's very easy. You put 2 electrodes and you have one number. We did this in sleep. It also goes down in sleep. It goes a bit up in REM sleep. We did it in the brain scanner, and then we could correlate that lower values of the BIS, as you can see here in 6 healthy volunteers, correlate with activity not just in arousal systems, but also in this frontoparietal network, as you can see in this slide. Now, I think there's a big debate about similarities and differences between anesthesia and sleep. This is one study we did with the group in medicine, looking at high-density EEG, slow-wave sleep, and then volunteers studied during propofol anesthesia, and I think we were struck by the very similarities of the topography and the different changes in frequency band when you compare physiological and pathological unresponsiveness. What I would like to emphasize is that if we're trying to understand the neural correlates of consciousness or how anesthesia knocks us out, it really depends on the tools we use. Do we look at brain metabolism with PET imaging? Do we look at bold fluctuations with fMRI? Or is it electrical changes? And on top of that, it depends on how we will analyze the data. Too often we want to be oversimplistic and just we look for one region going down or going up. And I think that the way we analyze the data, and this is an example where we use dynamic causal modeling, which look at interaction between nodes and more especially in the directionality between these interactions. And that, of course, is very important. We should understand that the brain is in permanent dynamics, and we should try to identify the changes of between and within network activity. And the point I would like to make is that consciousness, for us, with the current understanding, does not depend on activation or integration in primary sensory cortices. And this is a kind of older study where we presented auditory stimuli to comatose and vegetative patients, and they still activate their gray matter. You see here Heschel's gyrus in red, auditory primary cortex is still activating, but it seems to stop there. It doesn't spread to more associative cortices from which they seem to be disconnected. So when we look at patients who are comatose or vegetative, they can still activate their gray matter, but it's like an island. It's disconnected from the external awareness network, as we could show in these papers. And we only see this connectivity between, I would say, slave systems, primary cortical areas, and the higher order awareness network in subjects who were conscious or minimally responsive. And the same things have been observed in anesthesia. You see here the comparison again, studies showing that also in anesthesia you can activate your gray matter, but you lose this integration, this connectivity with the higher order frontoparietal networks. And again, using complicated mathematics, this is another example using dynamic causal modeling, you can look at changes in connectivity. And it seems that there's critical connections, top-down feedback connections. The red arrow here you see from these frontoparietal higher order awareness networks to the, in green, sensory, in this case auditory, slave networks. This feedback loop is only observed when you have a conscious or minimally conscious, in this case, subject, not in subjects who are comatose, vegetative, or anesthetized or in deep sleep. So, I think there's increasing evidence now to say we have a critical network. Consciousness is not just depending on overall brain activity anywhere in your brains. It's a specific network where we can divide external awareness, perceptual, sensory, coming through your sensory pathways, and internal awareness. And this is what these PhD and postdoc people from the lab did in healthy volunteers. They were put in an fMRI scanner where we look at so-called default mode activity. Your brain is always active. If I put you in an MRI, you will start thinking. And the only thing here that was set up is that they had a beep once in a while, and they were asked to score. I was more externally aware, or I was more internally aware just before the beep. Using fMRI, we can then look at brain activity, and you see if the scores for external awareness are high, like here, they have high activity in external frontoparietal networks. If the scores are high for internal, you see this midline core being more active. And at the behavioral level, if you look at their scores over time, which is shown in this graph, you see here that at any given time, it seems to be either one or the other. And I think we know this from daily life activities. Sometimes you are so absorbed in your thoughts, you will just ignore what somebody is saying. At other times, there's a lot of noise, and you will simply not be able to focus. And this is, I think, what this graph shows. It seems to be that you have these two dimensions, and they're in permanent competition with one another. And at the brain level, we see that there's two networks, and they're in permanent competition with one another. Again, a couple of studies. Here I'm focusing on results from our lab in Liège. Melanie Bowley used a laser and made it such that healthy volunteers were stimulated. They received a laser prick on their hand at threshold intensity. So half of the time the subject would say, I didn't feel anything. The other half, same intensity, they would say, yes, I felt it. You do that in an fMRI, you subtract both, what do you see? Not primary somatosensory cortex. You don't feel with your primary somatosensory cortex, just as you don't see with your eyes or your visual cortex or hear with your ears or auditory cortex. These are necessary but not sufficient. If you do the subtraction between perceived and unperceived, you see, as seen there, this frontoparietal network. Internal awareness for us, it's a bit more tricky to study. We've been using a lot autoreferential stimuli, such as the own face, the own name. I think it's also very useful for you anesthesiologists. It's attention grabbing, and studies have shown that these personally meaningful stimuli are very strong. It's from the own name known as the cocktail effect. When you're at a party and somebody says your name, it will grab your attention and pop out of the noise. In fMRI, we see that those stimuli, autoreferential, will activate your internal awareness network. Oops. Okay, in Liège, I'm sorry for... Okay. In Liège, we have quite a tradition, I think, with hypnosedation. It's using hypnosis in the operating room. Now, this is, I think, a challenge. Hypnosis has this charlatanesque history, and I think it's very useful, and it's interesting as a model, and has been introduced in the clinics by Marie-Lise Femonville, who I think was one of the first to propose what she calls hypnosedation, patients receiving benzodiazepines, pre-medication, and then for specific surgeries, they are in the operating room, conscious, and yet able to have the surgeon cutting tissue without giving any anesthetics. And she simply asked them to relive pleasant memories. So she sees these patients once and then asks, what do you want to think about some holiday at seaside or in the mountains? And it's really very impressive. When you're there in the operating room, they have now, I think, over 8,000 patients with thyroidectomy. The most famous patient was our queen, who had surgery, and plastic surgery, rhinoseptoplasty, where mastectomy also. Normally you would have a general anesthesia, and here you have this patient awake and just, walking on the beach. She came to see us in the lab, and she wanted to understand, well, what's happening in the brain. So we did the same thing in subjects who, healthy volunteers, underwent this so-called hypnotic induction. And what you see is that they will tell us they have this kind of absorption, right, as compared to the distraction task, and this is the neutral, normal waking. They will report some kind of dissociation from their environment with very little external awareness. Brain-wise, we see that there in blue, we see this external awareness network still present in the distraction task, but falls apart during hypnotic state. So going with the hypnosis that you're indeed able, just without any pharmacological modulation, to decrease connectivity in this external awareness network for, of course, some very specific types of injury where local anesthesia can be given. But I think it's an interesting way also to look at neural parts of consciousness. So these studies look at so-called resting state default brain function. And this is a quite recent field. Many colleagues initially thought, well, this is not convincing. These are artifacts. It's not coming from thoughts. And when we started doing this, we again looked at the extreme, at how these resting state default mode networks that you see identified here in this midline core, when we talk about connectivity, and there's different ways to quantify, to measure it, basically we do a cross-correlation. And so you would see that the midline frontal area in red and the in blue midline posterior one, they, if you look at their activity over time, go up and down together. So we call them functionally connected, and we think that this correlation over time somehow represents higher cognition. And to better understand it, we looked at the extreme brain death, and then, of course, it all falls apart. There's no change in resting state functional connectivity in brain death. However, there still is residual connectivity in unconscious states, such as anesthesia. Study here by our anesthesiologist, Pierre Bouvroux, using propofol. You see wakefulness, mild sedation, so patients being drowsy, sometimes responding to command, and then unresponsive, never responding to command, and then recovery. If we look what changes depending on these different states, we see the default mode network and, of course, the arousal subcortical networks in the brainstem and the thalamus. Interestingly, we do not see significant changes in the slave sensory systems. You see the visual network, present during waking, is still present during anesthesia. The auditory network you see here is still present during anesthesia. However, the cross-modal visual auditory interaction, as you can see on the right, does seem to correlate with the level of consciousness. And again, there's many different ways to look at this, which often makes it complicated, which makes that it can be confusing reading through the literature. This is a study where we looked at specific interactions with the subcortical arousal networks. And I think that it is important to emphasize, and this is one of the big, not disputes, but different hypotheses about loss of consciousness induced by anesthesia and the so-called thalamic switch hypothesis. Are you actually switching off a thalamus, and then the result is a turn off of cortical activity, or are anesthetics targeting cortical regions? Again, I will start speaking from my area of expertise, which is pathological coma. We know that these thalamocortical loops seem critical because they're the ones in this early study that recover when patients recover from coma or the vegetative state, which actually led the group in New York, Nico Schiff and his team, to put electrodes in these thalamic nuclei, in the non-specific intralaminar thalamic nuclei identified previously with neuroimaging, and could improve consciousness in selected post-traumatic minimally conscious state patients. So definitely consciousness requires a network, an interaction between thalamus and cortex, but I think at present it's still open what is the specific role of one or the other, and there's data in favor of both hypotheses. This is one study, again, doing dynamic causal modeling, and what we see is that in propofol-induced anesthesia, there seems to be a breakdown of long-distance connectivity and an increase in short-distance inhibitory connectivity in this auditory paradigm. But again, it depends on how we acquire and how we analyze. This study looked at both sleep and propofol anesthesia, emphasizing that it is both a change within network and between network, with, again, complicated mathematics trying to capture these physiological or pharmacologically induced changes. Now, I think clinically there is a major interest for us to better understand consciousness, to be very aware that what we're measuring at the bedside depends on a motor response. So arousal on itself is not sufficient to speak about awareness. The real challenge for us is to identify as soon as possible non-reflex behavior, and then next, the challenge of finding response to command, knowing that we can be biased in patients who maybe fail to understand the question. But then, of course, the next big boundary to access awareness is to share it, is to establish a verbal or non-verbal communication. So this is the timeline. If we look at consciousness plotted against motor responsiveness, we see after pathological coma, but I think after pharmacological coma, it is kind of a similar pathway. Of course, some of these stages can be very, very quick in your case. And this is important because I think that the rest of the symposium will also emphasize on the conscious perception of pain. Now, of course, if we already have a difficulty defining consciousness, we definitely have difficulties capturing pain. We will talk about nociception. Terribly difficult in the absence of functional communication, both in anesthesia and in coma. For the latter, we propose this nociception coma scale. Simply, again, quantifies the noxious stimulation, quantifies the way we standardize the motor response, verbal and visual, and offering a score we think represents possibly some conscious perception of pain. I think always interesting to validate this with now tools offered by functional imaging, and you see here one study showing that indeed this nociception scale score correlates with activity in regions we think to be critical for conscious pain perception. In this case, the anterior cingulate cortex, which together with the insula seems to be a critical node, again, in this pain matrix, because there is no such thing as a pain region in the brain. For example, if I would take the anterior cingulate cortex, which we think is important for the emotional affective component of pain, I could stimulate it by all possible means. It wouldn't give you pain, right? So pain is really multidimensional. It's, again, depending on network activity, and we should be very careful. However, despite all the pitfalls and difficulties, we try to use all these possible tools. Glucose metabolism doesn't depend on any question asked to the patient. Functional resting state activity, again, permits us to quantify connectivity changes in specific networks, as you can see here. And interestingly, we see this critical node always showing up when we compare a little bit conscious with unconscious. You can see it here, precuneus, posterior cingulate cortex, when we look at changes in resting state connectivity. So you see this progressive breakdown if you look at pathology, and you will see a similar breakdown when you look at anesthesia. Also note that even in deep comatose patients and deeply sedated patients, you still see connectivity because you're looking at a living brain. So what you're measuring here is a mixture of structural connections, and these are just imposed by anatomy, and the cognitive layer. And so I think we can use this in our advantage to disentangle the cognitive part, which of course is of interest to us. And so we can get all excited by these new tools, and we see self-consciousness. Here an example in a locked-in syndrome patient. I saw very difficult to see any motor response. You see the brainstem lesion. And of course, when you look at fMRI, I get all excited because I see these yellow blobs and I think I see consciousness. But I think we should be very careful. And sometimes it's a Pinocchio. It's not coming from the brain. It's not consciousness. And all these measures are very indirect. And we have no gold standard, which is also for you very difficult. How in the end do you know that you truly were looking at possible awareness during anesthesia? You're biased by many things. Patients telling you afterwards, I had this or that sensation, but when was it happening exactly? Difference between memory and awareness. So it's terribly challenging. And we're looking at tests we don't really understand. In patients, we don't really understand. And so we're often making this kind of circular reasoning error. However, tend to end with some optimistic notes. The tools we now have are really incredible. And I already mentioned PET imaging, fMRI, high-density EEG. Here is an example of combining EEG with TMS. And I think this is wonderful. It was developed by Marcello Massimini from Milano, you see here. And I invited him to come to Liège, put all his equipment, which is very expensive, $500,000, in a truck. And he's stimulating the brain with TMS, transcranial magnetic stimulation. We know this tool. You have an MRI. You navigate through the gray matter, and you can decide which parts you stimulate, you excite. And simultaneously, and this is tricky, you will measure the electrical response, the kind of echo. And there you can quantify the complexity of this induced imposed change. This doesn't require anything from your patient. He can be deaf, blind, paralyzed. He cannot be willing to answer, which is another big problem in some of our patients, and I think also yours. Patients sometimes just don't want to answer to command. Here, all of that is bypassed. You just knock on the brain and you read out the response. And you can then quantify the complexity, and we see clear correlations, in this case after coma, with the recovery of consciousness. So you see here patients who are unconscious with a very local, so the cross here is where we hit the brain, we stimulate with TMS, and the color is the response we get. You see a very local, stereotypical response, and it becomes very different as soon as patients recover some even minimal signs of consciousness. So we kept doing this in healthy volunteers, in sleeping volunteers, in anesthesia using benzodiazepines, xenon, very interesting atom, propofol, and then we proposed an index. This is quite provocative, from 0 to 1, and we tested Giulio Tononi's information integration theory, basically saying for a brain to be conscious, the information needs to be integrated. You can apply mathematics. Doing this, calculate what we call a perturbational complexity index, and you see that each and every time that the values are lower than 30%, subjects are unconscious, dreamless sleep, anesthetized, or, as shown here, comatose. So I think this is a very elegant new tool. It's expensive, it's terribly difficult to use, but there's room for improvement, and it again permits us to test our hypothesis in a quite, I think, unbiased way compared to the other studies I presented. So in conclusion, we've repeated it many times. Please remain aware that our clinical assessment of awareness depends on responsiveness, and unresponsiveness is not always equal to unawareness. There's the problem of amnesia. There's the problem of aphasia. There's the big challenge that we have no gold standard. And as said, we are looking at specific markers of neural activity, and they will be different if we inject glucose, if we look at bolt fluctuations, if we look at electrical changes, and each have advantages and disadvantages. It will be important to specify if we look at the brain in resting conditions, in activation, passive or active, and then the way we analyze the data, if they're hypothesis-driven, data-driven. But I think that there's now increasing evidence that human conscious awareness can be seen as this emergent property of the collective critical network, top-down connectivity. In this frontoparietal network we've seen in many examples where there's external awareness with, to simplify, external frontoparietal areas, and internal awareness with these internal frontoparietal cortices. Before we end, if I have one minute, because we're in Onze Lieve Vrouwen ziekenhuis, I don't know how to translate that, Virgin Mary Hospital, talking about consciousness. It's a very tricky subject, talking about the mind, about the spirit, about the soul. And before we leave, I wanted, of course, to thank the team who did this, but also discuss with you one project I didn't mention, which is our study on near-death experiences. I think they're a physiological reality. So if anyone out here has a patient who had such an experience, and maybe also it's a request not only to pay attention to possible awareness during anesthesia, but also to actually be aware of this possibility. Patients having these incredible claims that they left their own body, that they saw the light, that they felt incredibly well. we have now over 300 testimonies, and I think, again, this can be a useful model for us to better understand how a damaged brain during or after cardiac resuscitation, but also during anesthesia and surgery, you have many of these stories, can still have these very rich subjective experiences. So this is our email address, coma@ulg.ac.be. We need many, many more of these testimonies because it's a very, very challenging field. Thank you for your attention.